So again, once more, welcome everyone. We'll go ahead and start discussing the article. And I hope that you all received it. So the article I sent out is called The Interaction Between Vestibular Compensation Mechanisms and Vestibular Rehabilitation Therapy, 10 Recommendations for Optimal Functional Recovery. It's kind of a long way of saying what I would have called 10 tips on how to improve your outcomes with vestibular rehab or something to that effect. So it's not much shorter, but anyway, that is the gist. So go ahead and I go through the review. So first of all, kind of the background. I always like to give a little bit of background from the article. What they described was, of course, kind of a quick summary of the vestibular system, which contributes to posture and oculomotor control, which we all probably know, and kind of that integration between those things and the sensory and motor signals coming from elsewhere in the body, vision, proprioception, that sort of thing. And of course, the vestibular system also contributes to high level cognitive processing. So that includes space perception, navigation of space, body representation, attention, memory, mental imagery, and social cognition. So kind of a wide array of situations where the vestibular system contributes to what's going on with us, kind of knowing where we are in space, things like that. And social cognition, kind of an interesting term. Of course, I did have to look it up because I'm like, what does that exactly mean? And what they described that as when I looked it up was the processes involve perceiving other people and how we come to know other people in the world. So it's not quite recognition of people, but it kind of feels like it's in that genre. It's kind of interesting to think about the vestibular system coming into play with our social interactions and perceiving people in our space, seemingly both physically and emotionally, actually. So we knew the vestibular system is pretty important, right? But it's just kind of interesting to see the long list that this article provides or suggests. So this is pretty important because, of course, we know some people have vestibular dysfunction, so they go on in the background to talk about that. And they talk about kind of when the vestibular system has an issue, what does that look like? So they describe what they called static and dynamic symptoms. So the static symptoms they described are some that you would probably see mostly early after a vestibular or some kind of cause of a sudden hypofunction, we'll say, or a loss, whether it be partial or complete. So spontaneous nystagmus, skew, some vertigo, but head and body tilt, what they call eye cyclotorsion, which I feel like is like a torsion component to the nystagmus, perhaps. Subjective visual vertical, and some nausea and vomiting you might see. So those are kind of like immediate with kind of spontaneous body presentation, we'll call it. Then the dynamic symptoms they describe are kind of effects on the VOR, right? So vestibular reflex is impaired in gain, phase shift, reduction in the time constant on the affected side, and then the functional output of that, I would say, which is impaired balance. And this article states that those dynamic symptoms remain poorly compensated and are exhibited over a longer period of time than the static ones. And I think we probably have all pretty well seen that in practice and would agree. So keeping that in mind, they kind of jump into the idea of compensation and what that is. And they describe kind of in detail what that is, but they also describe why it's important to help improve it. And they give 3 reasons for that as well. So first of all, they describe the high prevalence of vestibular dysfunction, and they have it at the 30% mark for age 40 plus, or 35%, I guess, roughly, close to 65% over age 60, and then over almost 85% for those over 80. So we also are probably familiar with these numbers, not a big surprise. They talk about the impact on quality of life for these folks, which again, I'm sure we've all encountered this, and that increase in anxiety and depression is a common one that they mention as a real issue. And last but not least, they describe how spontaneous recovery is not optimal. And there are multiple studies on this. And they talk about how, folks who are kind of trying to compensate or recover on their own sometimes do fine, kind of functionally turn out pretty well, not a lot of symptoms, but other ones develop these kind of maladaptive strategies, like I'm just not going to move my head. And so, I call it that turning in block, right? Kind of head and body moving together, Frankenstein mode, however you want to call it. So, we want to kind of address that with some sort of rehabilitation. And this is what they recommend. So they talk about the ICF disability definition of rehabilitation to kind of promote optimal functioning in physical, intellectual, psychological, and or social domains, and that is evidence-based practice to do so. But then they go on to, of course, to kind of describe the literature on vestibular rehab as it stood when they wrote this article a couple of years ago. And they suggest kind of 10 recommendations. So here we are. I would call this the meat of the article, is these kind of 10 recommendations for kind of, again, optimizing patient outcomes, right? So the first one that they recommend is that vestibular rehab be active. So being vestibular rehabilitation clinicians, I think, again, we're kind of sold on this, but we probably are aware of some clinicians in the healthcare space that are maybe not as sold on the value of active rehabilitation. Oh, the patient, has had this neuritis, they're just going to get better on their own. They don't necessarily need therapy. So some clinicians feel that way, but the literature, at least what they pull for this article, does not really support that. So they talk very specifically about some pretty interesting kind of brain level changes and kind of some pretty cool studies that they have kind of either done themselves or I think mostly pulled from other resources about kind of the feedback of the central nervous system, kind of how the brain, is changing during this kind of sensitive period, which they get to in the second recommendation, as far as kind of these feedback and feed-forward mechanisms that are used to recalibrate the impaired vestibular function. And they go into the upregulation of neurotrophins, increased neurogenesis, right? So actually nerve changes that they can measure. Now, a lot of these are animal studies, but it seems pretty consistent amongst the different types. So I think they're pretty sold that this is what's happening for humans. And then they talk about even improving learning and memory by doing this kind of active therapy. So, that's kind of the take home to me is ways that we can try to maybe break the science down a little bit to help better educate our maybe fellow healthcare providers in some cases, as well as patients, family members on the value of therapy. And so, kind of how do we explain this without, using too much jargon, things like that, but really to kind of be able to sell the value, which again, as clinicians who do this every day, we already are probably sold on it, but it's about other people, right? Not just us. So the second recommendation, besides that it be active, is to start early. So they talk a lot about this kind of sensitive period. And they did some pretty interesting studies on cats. And I looked at what year the one study that they really kind of describe heavily, and it was done in 1980. So that doesn't make it, less valid, but I just wondered when it was happening. These cats getting unilateral lesions so that they could figure out kind of these different aspects about the timing of input. So specifically what they describe is a couple groups of cats. So there's one group of cats who had a 1 week sensory motor restriction applied at the acute stage. So that's first week post-op. So they're actually creating these, right? So kind of like an acoustic neuroma situation rather than a neuritis, but, you know, kind of in the same genre, I would say, because it's sudden onset and all that. And then they also had another group where they applied a restriction during the early stage of compensation. So they said the third post-lesion week. And what they found that both had effects on their time course and recovery. So not only were there static and dynamic equilibrium, so balance testing, so to speak, of the cats, was strongly delayed compared to the unilateral lesion cats without restriction. But they also found that the final level of recovery was drastically reduced, 40% and 50% kind of the unrestrained animals respectively. So in other words, the acute just 1 week restriction were 40% less, had less, reduced performance, I guess is the word I want to say. And then the folks, the cats, excuse me, who were restricted through the third week post lesion had a 50% reduction in performance. And they said when they kind of restricted a cat after they were totally compensated at 6 weeks, then that restriction didn't have an effect. So, kind of, if you kind of stopped moving later, it was okay because you already compensated versus restricting in that early 1 week to 3 week range is what we were looking at, or they were comparing. So this critical period is a pretty big deal because for me, I've had patients who definitely never had vestibular rehab, and I am finding that they have what I'm pretty sure is an old, meaning months or years out, vestibular hypofunction. I don't think it means that we can't have effects on those folks, but it's just kind of pointing out that if they miss that critical period, there can be some impact on their ability to recover. And again, this kind of just would be an education piece potentially for any healthcare providers or patients or family members who, were not aware, that this is something that we should be doing, is kind of starting rehab early. And I think there are plenty of physicians, for example, who, are good at referring post-op patients from acoustic neuroma early and often, but not all. So that was number 2, right? So moving on to number 3, I would say they said to be aware of the instructive role of vestibular rehab. So this was, again, kind of animal studies, so interesting approach where they talked about exposing these cats again, or I guess they were maybe different cats, but still cats, to a group that was exposed to light or housed in the light. The second one who received passive optokinetic stim, but sensory motor restricted. And the third group was free to move in the environment and actively received the same optokinetic stim as group 2. And what they found with this study is that the cats who engaged in the optokinetic stim environment exhibited the strongest increased neural responses. So they were really looking at those cats as getting, again, more gain. So this is kind of back to, I would say, that it's not just about moving around in your usual environment and just kind of passively receiving information, but kind of providing some sort of formalized input as a way to stimulate recovery. And they went on to talk about something that I was not really familiar with, which is a drug that they could use to block neurogenesis, and kind of just showing that neurogenesis is actually happening. So, it's not just at the brain level that they're getting recovery, but really at the neuronal level and the vestibular neuron. So I thought that was interesting. And they talk about how vestibular rehab can shape and refine the reorganizations as a top-down process through specific interventions. And they don't get into what those should be at this point, but they do get into that later. So that's okay. So what is true, they say, is that the timing, type, and intensity of vestibular rehab should be crucial factors. And they kind of have some variations that you need to take into consideration later on in the article. So I feel like this is very similar to the fact that the rehab needs to be active, but instead of just saying you need to move around, they're saying you need, kind of more specific inputs that are guided. That's what they're trying to say with this. I kind of wish in this section they had a kind of description of like humans getting vestibular rehab and some articles about that, but they focus on the cats. So here we are. Number 4 is the favorite adaptation rather than habituation. So they define those things, and they also define restoration. So let's talk about all 3. Restoration would be restoring lost function. So this is really, in a practical sense, implanting a vestibular implant, right? The way you would do a cochlear implant for hearing. And they have done that, and there are studies that they are actively running on mostly patients with bilateral loss to, kind of improve their function and quality of life and things like that. And they've had some good outcomes. And of course, there are risk factors with that sort of surgeries in those areas and things like that, as far as hearing impact potentially and whatnot. But anyway, that would be restoration. Then they describe adaptation, which is a learning process where lost function is not restored, but replaced by a new operating mode using either sensory cues or a newly elaborated behavioral strategy. So then they break that down a little bit, and they talk about an example of each. So as far as sensory cues, the example they give is kind of using your vision to formally try to kind of orient yourself. And they kind of reweight, right? These sensory reweighting, you might have heard of that. And then you can also use proprioception to help reweight, to kind of fill in for that vestibular system a little bit. And then they talk about behavioral. So this is where either consciously or subconsciously you're using a strategy. And they talk about microsaccades, which of course is kind of a substitutive strategy for a non-intact vestibular reflex, right? So instead of having this automatic pilot, so to speak, we're having these little tiny eye movements that also can become quite automatic, but are kind of a new automatic pilot for having gaze stability. Habituation, then, the third thing they define is the progressive reduction of a response due to monotonous repetition of the same stimulus until the response totally vanishes. And we're familiar with habituation, and they do go into when it could be useful, for example, for patients with visual vertigo. And so they're not saying that habituation, I think, is bad in general, but specifically they want folks to focus on adaptation as much as possible for folks with unilateral hypofunction. That's kind of the message I got from this section. And then they talk about an interesting thing that I had kind of heard of but didn't know a lot about, which was kind of this electrotactile substitution system, kind of using tongue stimulation with a little bit of electricity to provide information about the patient's head position, and that they have found that as kind of an interesting, useful tool for patients, again, with bilateral loss, since they are the most impaired. They're probably going to be more open to more novel treatments, I would say. And they've also tried it, at least, I guess, in patients with some other peripheral and central vestibular loss. So there's some inconveniences to having electrical stim on your tongue, I suppose, but it was just kind of another interesting way that they were suggesting you could provide input, kind of sensory substitution type situation, I would say. Oh, got a nice chat. Interesting. PONS uses the same electrostim on the tongue to improve balance. Yes, I've heard of that as well. Good point. So yeah, I think it's one of those things that's definitely being studied more than being used practically yet, but it'll be interesting to see if that evolves into anything more, or at least adds more to the literature. Oh, thank you for defining the PONS. Portable neuromodular stimulation. Oh, for brain injury. Right. Yeah, and I've seen it with stroke too. I think at least at one conference I went to, they were at a booth. Right. Yeah. So it's a way to kind of, again, provide sensory input, I think, globally to folks with neurologic conditions that might need that to help them with something like balance. And I guess it's still a vestibular benefit in some ways if they're getting the head position in this kind of type of setup they're describing here in the article. So that was kind of an interesting little tidbit. So we're halfway there. We're at number 5, and that is do not use a stereotyped vestibular rehab protocol. Hopefully you guys are already believers in this as well. And basically they talk about, as a therapist, how you need to observe what maladaptive strategies might be happening, correcting them. So if they're avoiding by limiting their head, not moving their head, which we talked about. If they're blinking quite a bit during head rotation to limit their vision, like some kind of significant blinking that you can notice. And it's okay to blink a little bit, right? But, you know, where they're really kind of just limiting sensory input, I would say, rather than kind of trying to sensory integrate, which is what we prefer to see. And they talked about using the dynamic visual acuity test as a way to kind of track progress as you help a patient move into adaptation. So hopefully that's something you guys are all familiar with, that test. Kind of a quick and easy eye chart test. And there are computerized versions of it as well. So anyway, they certainly did not go into like exactly what to do per se again here, but they at least kind of point out the fact that it shouldn't be cookie cutter, which I think we can, again, hopefully all agree on that. All right, number 6, take into account the sensory, motor, and cognitive profile of the patient. So this is kind of poning off of don't be cookie cutter, I would say. And that you have to really kind of understand where the patient's coming from. So if they have other neurologic deficits, they have had an old stroke in the past as well, and now they get this new unilateral hypofunction, or if there's somebody who, you know, has more cognitive issues coming in the gate. They talk about Meniere's as being, you know, folks who have had more fluctuations, and so they've had kind of to adapt on repeat in a way, but in some ways that's maybe good that they've had that practice, but also it can be pretty wearing and challenging. So, and obviously they kind of compare unilateral and bilateral as being different kinds of patients that you're going to have to provide some different strategies for in some ways. And they had a nice comment here. Taken all together, these data show that sensory cues substituting for missing vestibular information vary widely among individuals. So again, kind of like looking at what cues people are good at using, how they're using them, again, what they might need to be cued to use more, you know, kind of how to determine even like, again, subjective visual vertigo. Do you train that? Do you use, you know, different cues in the environment, whether it's kind of just cues that are already there, like, you know, kind of the line that runs up and down along an edge of a hallway or a wall or kind of a mirror, right? There's lots of ways to provide cueing and input. And they do encourage using, you know, kind of that body awareness as well as visual, right? So don't kind of lean on just one, but those are kind of 2 other sensory systems that we can use. So we have to kind of fight too strong a dependence on a particular input, which can require us to then habituate somebody, if, for their example, too visually dependent. So it's a fine line, right? Number 7 they go to is be careful with the therapeutic progression. And this is still a true statement, even though it's been a couple of years since this article was written. There are no generally accepted guidelines and no definite recommendations concerning the different facets of vestibular rehab therapy. That is the timing, type, intensity, and duration. And I know that patients and clinicians probably all wish this was not true, but I know they're working on this in research, but we're not there. So they do have some general principles and recommendations. So they talk about what I think is taught in most courses, hopefully, which is kind of the seated to standing to balance challenge to walking and movement of the body progression, and then kind of gradually increasing head movement speed, and kind of seeing it as a sequential process with intermediate goals or a stepwise learning process. They do recommend using antiemetics or anti-vertigo drugs only within 2 to 3 days of vestibular injury and then discontinuing. And I think we've definitely seen lots of patients who come in and have been on something like meclizine for a while, maybe months or years after they maybe had a vestibular loss. So that's something to consider and work with the physician on, and the patient to be open to hopefully not be utilizing those because they can be kind of inhibitory to progress, inhibitory to adaptation sometimes. And they talk about kind of if you don't attend to the progression, like that can lead to poor recovery, and also some secondary issues, like again, this kind of long-standing issues of anxiety and depression, things that can come up with vestibular loss. So that leads us right into point number 8, which is you should reduce anxiety and stress. So basically they go into the science of it. I'm not getting into it here because we're running short on time, and they talk about the hypothalamal pituitary adrenal axis and kind of how that gets activated in this process and can kind of remain permanently activated, or at least for a long time after the lesion has occurred. So they just kind of don't get into a lot of recommendations on how to help manage that. I think they're leaving you to kind of figure out the usual suspects of medication or kind of behavioral therapy or some sort of other support. And I think education, at least my opinion, that's a huge thing for the patient, is kind of to know that the recovery can vary, to be open to that, to, you know, just keep working at it. And, you know, yeah, we can talk more about that. I'll do you guys hear you guys' inputs on that section, because I think that's always a tough one, is how do we help the patients who are feeling more anxious about this situation of having a loss. Moving us to point 9, favor ecological situations and concepts. So this is really treat again to the patient, but including like, what are they going to deal with? Are they going to be in a grocery store? Are they going to be going back to work? Like, you know, how do you integrate like kind of activities they enjoy, like Tai Chi and things like that? And they talk about some kind of technology, and that leads us right into point 10, which is to motivate the patient. And they talk about using kind of video games, and I'm definitely a big person for games. I don't usually do video games, but I have a lot of other like kind of fun games like Spotit that I like to play. And that seems to really also be helpful to the patient. So they also talk about motor imagery. I probably don't use as much of that as maybe I should, which is a whole concept and a separate topic we could get into, but basically kind of having the patient practice and do mental practice. So that hits the 10 points. Hopefully you're doing all of them already and you're like, oh, I already knew all this. This is great. It just reaffirms what I'm doing. But I'm interested in anyone's input, either in the chat, or if you want to put your sound on, you can speak. And if you want to put your video on, feel free. It's only up to you. But, you know, my first question would just be, as far as the anxiety and depression piece, kind of how do you, whenever you get the patient, so say you get the patient kind of even a week out, or whether you get them a year out, and you notice that that seems to be a piece that's going on, what are your kind of first steps, or kind of how do you address that or try to support patients with those things? What are some tools that you might use, et cetera, and so forth? What do you got? Oh, got one here. Talking about sleep. Yes, sleep, very important for the brain and all neurologic conditions, right? And mindfulness, okay? And then I have something else here. Education about the vestibular system helps a lot. Yes, so definitely educating the patient on kind of the, not with the jargon, but just kind of the recalibration. I liked that term. That's a term actually I've already been using to kind of say, well, your brain has to kind of reset button a little bit, try to help that, you know, vestibular nerve that isn't able to do 100% anymore, that kind of thing, right? So we do that education. And let's talk a little bit more about mindfulness. So does anyone have any specific tools for mindfulness that they like to use, an app, or kind of just training them? Do you actually take them through any mindful exercises? I'm really interested in that. So here's a person saying we are using home exercises, surface orientation. So some people call that grounding, I think is what you're referring to, where we kind of just think of ourselves as being planted and feeling the surface that our feet are on, or our bottom if we're sitting. Kind of, I call it plugging into the wall, like you're a plug going into an outlet. There's a lot of ways to kind of use analogies there. And then for apps, I see we've got Headspace, And MedBridge has mindfulness, some 1 to 20 minute videos. Oh, I didn't know that. That's cool. So Headspace I'd heard of. I haven't actually tried it though. I should try it just because I don't like to instruct people on something that I haven't tried myself. Stephanie's also saying she utilized the MedBridge resources. Nice. Okay, cool. Now, are most MedBridge resources only available if you like are paying for MedBridge as a clinician? Okay. Yes. All right. So good to know. So if you're looking for truly free stuff, then maybe not. But a lot of people are on MedBridge anyway, so might as well use what's there and maximize your benefits, right? Cool. Has anyone referred to a clinician, like a kind of behavioral therapy or psychiatrist for your patients? And what cases might that be where you would go? Ooh, and Craig says, if it's stress and anxiety, also review the ways they can release endorphins. Yes, exercise, right? Yay, exercise. Smiling, all the good ones, right? I should actually make a little handout. That's actually a brilliant idea, Craig. I like it. How can I release my endorphins? Probably all the patients need that. Good laugh, music, sex, sure. All good ones as well. Yeah. Okay. Good. Yeah, I have referred a couple patients, usually the more chronic, kind of long-term dizziness type patients, I feel like can sometimes benefit from counseling or cognitive behavioral therapy. Oh, somebody else says, I've talked to patients about doing progressive muscle relaxation. Yes. Some people call it like a body scan, like in yoga. Perhaps I've done it, like relax, soften the jaw, right? Like kind of coming down, and it can be a good way as well. Good point. Cool. All right, good. So a lot of good ideas here. So my second question then is, again, kind of leaning towards the end of the article where I think it's most useful. How might we, kind of what is the most fun or effective, or hopefully both, kind of ways that you're incorporating kind of this ecological kind of environmental type exposures, kind of help mimic the patient's like work environment or home environment, things like that, with activities to stimulate the vestibular system, and kind of meshing that with the exercise you're doing either in clinic or at home. And anything you're doing that's kind of super interesting, like are you using virtual reality, any kind of games? What do you got? So one thing I'll kind of put out right away is that, and I'm always gathering more and I need to add more to my list. So I have a list on the Vestibular Rehab, or sorry, on Vestibular First site, there's an article that's called Essential Equipment. And I have like a couple games on there. So I mentioned Spotit before, because that's cards where there's always a match on both cards. I have them reach for the cards, so they have to kind of turn and work their balance a little, and then they have to kind of turn their head to find the matching object. They're working cognition, spatial, all those things, right? So that's an example. Ooh, I see somebody else is using Spotit, working different angles to work on saccades. They do have different versions. Yes, I love the one that I can't even find it anymore. Hopefully they're making it again. I haven't looked in a little bit, where it has words and pictures. I find that's like a good cognitive challenge as well, instead of just pictures alone. But either way, Spotit is great. And then we got some other input here. No virtual reality yet. So, oh, badminton. Oh, that's a good idea. I've never tried that. I have done ping pong, which is in the genre. But yeah, badminton is good. I like it. A little competitive edge for folks who are into that kind of thing. And again, just kind of making it more fun. Nice. I'm jotting that down. Badminton. I like that. Okay. Cool. Any other fun ideas, novel ideas? Probably most people have done just walking with head turns, tossing the ball, things like that. Badminton is easier than ping pong. That's a good point. Boxing to targets with shed turns. What's a shed turn? Oh, I'm learning new words now. Oh, head turns. Like, what's a shit turn? All right. So boxing to targets with a head turn. So we're like kind of, all right. I like it. Boxing. Good. Walking backwards and laterally. Yep. Done that. Those are good ones. You're a terrible typist. No, you're not. You're doing great. Yeah. So boxing. I like that. Cool. I love ideas. Good. Cards. Yes. Yes. So all kinds of games, right? I think so. Can use playing cards or kind of regular standard cards. Again, you can use Spotit. You can use, I have one that's called Color Smash that I've been liking. It's kind of like a yes, no type thing where like it's red, but then does the word say red or not type of deal. It's a little hidden. So that's good. I have one that's a little bit easier, which is good for depending on the cognitive ability, called Blink, where you have to find either a match of how many objects or the color of the objects or the shape. So Blink is another one of my favorites. What other card games can we use? Any virtuality ideas, especially with the new VR gaming technology. Any ideas? Yeah, I have to admit, I have not delved into that space, but I'm super curious about it and we'll be doing so soon because I'm hoping that we can actually make a treatment unit at some point in our roadmap. So that is something I'm excited about. But yeah, what do you guys, anyone using VR at all? No one so far? I know there are therapists out there doing it, but when I've walked around at conferences and seen what they have, of course, the barrier as usual is cost. Craig says we have not ventured much into VR, but we use basic goal setting to exposure to stimulating situations itself, malls and outings. Patients seem to like goals. That's a good point. So goal specific. I am definitely sending people to stuff they enjoy. I had a patient who was kind of hesitant to go to the CVS. She loved to shop at CVS. I don't know. That was her store. You know what I mean? So yeah, trying to dig into what they like with hopefully not breaking the bank. But yeah, that's a good way. And I always cue patients when they're in those kind of busy environments to still I use a lot of visual fixation, kind of fixing their gaze on certain objects to kind of orient themselves a little more, or maybe pause, sit and ground if you're feeling a little bit sensory overwhelmed. So those seem to be good kind of strategies to improve their ability to kind of tolerate a longer time in those environments, right? Good. Yeah, and I do use a lot of the videos. I think you guys are probably all familiar with the different videos that are on YouTube. Gabriel Pierce is my favorite kind of collection of optokinetic videos. I know Emory has one too, but Gabriel's is like pretty comprehensive. The only challenge is like, depending on the size of the screen you're using, it could be maybe too hard, but often too easy. Like if they're only using their cell phone, it's not probably gonna be enough STEM, I feel. But yeah, I don't have like a fancy Burtec egg or anything cool, but work with what you got. That's my motto. I've also been playing with Tappet a lot. So Tappet, I call it like the poor man's Blaze Pods or Fit Lights. I don't know if you guys have either of those. So Tappet is like a $30 game, and it's just it's almost like Simon or whatever, the one where you kind of have to, there's a memory game where you have to repeat and hit the right colors button type situation. But I like to do it where I set up just maybe one or two, or well, more than one. So 2 or 3 pods at least. There's 4 is like the max, although you can buy more if you want. And then they have to, like, I like the memory game because it works the cognition. So they have to tap, and kind of turn to the whichever side it was lighting up. So Tappet's an idea for anybody who would want to kind of do that and can't afford Blaze Pods or Fit Lights like my clinic. Good. And then I like to do even like work specific stuff. So like I have this, like, I buy a lot of games that are not really meant for vestibular rehab, and I just turn them into that. So like I have this alphabet mat, which is like this big like kind of plastic, I don't call it like a picnic blanket, but just kind of a flat thing you can lay on the ground, and has all the alphabet letters on it. It's for kids like to learn spelling and stuff, I think. But I'll have them like either bend down and come up so they can work on, I wouldn't call habituation, but just kind of repeated movement that they can kind of, be going different directions, stimulating their vestibular system. And I had this guy who was an ICU nurse. And so I was giving him words like pulmonary edema, and he had to like bend down and tap the P and the D or, whatever. And I had them do that. Obviously they could maybe do it just with their foot. And that's kind of more like standing and turning versus having to bend down. So there's different ways and different body movements to do it. And I'm always using like my cones and my rings and my bean bags and throwing stuff around. And it's only hard if they don't have like, maybe they have a stroke and they can't use one arm or something. It's a little harder, but yeah, you can kind of get creative. All right, I've talked for a while. I'm way over time, I know. This is a longer article, so it's a little more to cover. So kind of parting shot thoughts from anybody as far as anything you got out of the article, things you didn't know, kind of why you're glad you read it or maybe not glad you read it. I don't know. Either way. I'll say that to me, the biggest benefit to reading it was it got into a little more of kind of the neurology science of like kind of compensation and adaptation and recovery and what that looks like kind of at a neurologic level. And even though some of that I probably have heard in a course or something, it was just nice to kind of hear it in a summarized way. It's nice to like feel fully educated. And then, again, depending on who you're speaking with, whether it's another healthcare professional or a patient, or a family member, to be able to explain things a little bit more at whatever depth makes sense for the situation. So we have a comment here. I think it is good to have more data to support early rehab to give to providers. Yes, so I was already picturing like a cool handout. Maybe I'll make one and just post it up so everybody doesn't have to do the same thing. But, sometimes it's fun to make your own too, because you can tailor it to your particular physicians or region or what have you. But yeah, I think this is a nice summary of like the value of starting early rehab for anyone with any kind of vestibular hypofunction, bilateral, unilateral, acoustic neuroma resection or neuritis or, even autoimmune or what have you, right? So I agree with that. Good support. So I'll be using this article for that for sure. Anybody else got some good out of it? Great review. Oh, thanks. Yeah, I mean, to me, I stumbled upon the article. Somebody else had shared it on another group, I think, or something, one of the dizziness groups I'm on, and just seemed like a good thing to talk about in journal club. So yeah, I think it's a great article too to give students or newer clinicians, because I think it's a lot of the things that would be covered there that they would maybe not have ever heard, depending on what, if they've had a course or what they've gotten in school. So I think it's a nice, really good, like solid, like if I only could give 5 articles out to like a student to read when they're a few weeks in or something, you know what I mean? Like, so I think it's like kind of a foundational piece, if you will. So, for anyone who's really experienced, most of us are going, oh yeah, of course I do that. Of course that makes sense. Because either they were told that in a course or you figured it out on your own along the way, but it was nice to see it kind of nice and summarized and really kind of thoroughly done. So thank you guys for your time. And I know I went over, but this is a long one. Yes, put things together for sure. I like it, a keeper. Yeah, I agree. So definitely a keeper article, and a useful tool for you guys. So that's the goal. And we had like 40 some people register for this. I think most of them couldn't physically come, but they are excited to have the article. So good to share these resources. And we'll do our next journal club May 18th, again, Tuesday, 9 p.m. And thanks for sharing. And I like these journal clubs. Good. Looking forward to the next one. Okay. So yes. So I'll make sure obviously to put up on social media and our website, I'll give the details and what new topic I'll decide upon based on feedback from you guys. So if there's any particular thing you're interested in, feel free to chat me up or shoot me an email, let me know. But I always have like 20,000 things I want to learn about. So in case you don't send me anything, I'll figure out something hopefully interesting for you guys. So looking forward to it. All right. Thank you guys. Have a great night.